and welcome to Voices of Wisdom, Tyro's podcast, designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. You can think of it as kind of a fireside chat where we talk to international experts who share their wisdom and offer practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm a head and neck surgeon at the Gustave Roussy Cancer Center in France, and I am very excited to be your host of Tyro's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasica, who pioneered these podcasts. I want to take this opportunity to thank Janice for all of her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. In each podcast, we will be meeting with one or several international thyroid experts, and each episode will dive into a specific topic related to thyroid cancer care. Our aim is to help clinicians deal with issues that are often complex, and our aim is to provide as much evidence-based information as possible, but also practice-based information and tips from world-renowned experts. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. In today's episode, I'm thrilled to have Dr. David Pattison with me to unravel the mystery and help clarify how, when, and why one should use radioactive iodine treatment. Dr. Pattison is a dual-trained nuclear medicine physician and endocrinologist. As the Deputy Director of the Department of Nuclear Medicines and Specialized PET Services at the Royal Brisbane and Women's Hospital in Australia, he brings his unique and invaluable insight into this area. So we're going to jump right in. Welcome, Dr. David Pattison.
Thanks, Dana. Very happy to be here.
So we're going to talk about today something that I find to be a tricky subject, a radioactive iodine, which can seem to be something of a mystery for those of us who aren't lucky enough to work side by side every day with nuclear medicine physicians. So the idea today is to unravel some mysteries and really clarify some ideas about radioactive iodine. So first of all, what are we really talking about when we say radioactive iodine? There are different types and different uses. Can you explain the differences?
Yeah, sure. Look, radioactive iodine is an isotope of iodine, which means that it undergoes radioactive decay. And so during this process, it means that it emits energy in the form of radiation with properties that can be used for both imaging and therapy. So specifically, we're talking about ionizing radiation. Now, that means it's got enough energy that it can knock electrons out of atoms, and that can pose harm to living things, and fortunately can be harnessed to treat cancer by damaging DNA. Now, this is different to non-ionizing radiation you'd be familiar with, which is things such as light or radio waves. Now, there's really three main types of radioactive iodine which is used in thyroid cancer management. So there's iodine-131. This is most commonly used for I-131 therapy and post-therapy scans on a gamma camera in a nuclear medicine department. There's also less commonly used isotopes such as iodine-124, which is more recently used in specialized centers for accurate imaging on a PET camera and dosimetry, including trials. There's also iodine-123, which is just used for imaging of thyroid cancer on a gamma camera. And it was really used probably 1 to 2 decades ago, but has much more limited use these days. Now, there's some specific characteristics of these isotopes that are important to understand how they're used. From a chemical perspective, they all behave exactly the same, just like the regular iodine that we ingest in our diet, but it's really their radioactive emissions as they decay that are relevant to how they're used in thyroid cancer. Now, there's 3 relevant types of emissions I'll discuss today. There's gamma rays, beta particles, and positrons. Now, these are all quite complex sounding terms, but basically a gamma ray, these are like pure energy rays. So they're like light, but they have much more or much higher energy. And these can travel straight through tissue and would take up to 1 inch or 2 of lead or even a few feet of concrete to stop them. Now, it's a similar principle to light in a traditional camera, that these rays can form images on a gamma camera or SPECT CT. And now this technology has been around for many decades. But these traditional nuclear medicine or gamma cameras, they have parallel lead collimators. So that means they only capture these photons of energy which are traveling directly toward the detectors. And hence only a small fraction of the energy from the iodine is captured to form an image. And so it's quite low resolution. And it's for this reason that nuclear medicine has previously, I'd like to say, been referred to as unclear medicine. The other types of particles is beta particles. Now, these are different because in addition to having energy, they've also got mass. And so they have much more ionizing power or a greater ability to damage tissue than gamma rays. And typically they deliver their high energy over a distance of just a few millimeters in tissue from wherever they're localized. And these can be stopped by clothing or even a thin layer of aluminium. Now, the final type of radioactive emission I'll talk about is positrons, which are used for PET cameras or positron emission tomography. Now, these are actually positively charged antimatter, okay? And this travels a short distance from its origin, usually, again, just a few millimeters, where it interacts with an electron, which is matter, and this leads to annihilation, and it's simultaneously converted into two gamma rays, which are emitted in directly opposite directions, 180 degrees apart. Now, it's these gamma rays which are then detected by a PET camera. Now, this is called coincidence detection because, through some fancy computing, the PET camera is able to detect only those events that occur directly opposite each other on the PET camera detectors, and hence there's no need for a lead collimator to really dilute the energy involved. And it's one of the reasons why PET images have such high resolution. And now the way that this is relevant to the different isotopes is that I-131 is a bit like an all-rounder. Well, some would say it's like a jack of all trades and master of none. It's got predominantly a high energy beta particle. And so this is useful for therapy. And it's why we give radioactive iodine to treat thyroid cancer, where it delivers that intense radiation within just 1 or 2 millimeters at the sites where it's concentrated, like in the thyroid bed or distant metastases. But it also has a high energy gamma ray that can be used for imaging. And it's that, unfortunately, because of the high energy associated with it, it's not really perfect for imaging. But after you've given a high dose for therapy, it's reasonably accurate to see where it's gone in the body. Now, when we're using it purely for imaging, we don't tend to do that much at our centre. It has been used traditionally. It's still used in this way in some practices. If you do just pure imaging with it, you need to give a low activity because of the beta particle associated with it. That can cause stunning. So it can sort of damage any thyroid or thyroid cancer cells there, such that if you then follow up with a higher dose of radioactive iodine, it may not have the same efficacy. I-123, so that's another form of iodine, not used so much anymore. It has pure gamma emissions. So it means it can be accurately imaged on a gamma camera because you can give a slightly higher activity because you're not worried about stunning. There's none of those beta particles that can cause that, temporary or transient damage to thyroid cells. And it also has a significantly higher resolution than I-131. But for a few reasons I'll explain later, we don't tend to use that so much anymore. I-124, however, that has a variety of emissions, but the main one that we use is the positron emission, and it's got a half-life of just over 4 days. So this can be used for quite high-resolution PET imaging, and because we're using a PET camera, we can use it for really absolute quantitation and dosimetry, so we can see just how much of the iodine is going to any region in the body. And in this situation, we tend to take images at set times, even over a couple of days, and that's to determine whether the radioactive iodine therapy we subsequently give is likely to have an effect. And this is very relevant to something called Theranostics.
You make it sound so easy, David.
Yeah.
So Theranostics is a word that we're hearing more and more. Can you really explain that to us, what that is? Diagnostics plus therapeutic. What part is diagnostic? What part is therapeutic?
Yeah, sure. Look, it is an interesting term. It is bandied around a lot these days. And essentially, it's described a lot for treatment of prostate cancer. Now we have Theranostics, and in NETs we have Theranostics. But these principles are really very relevant to thyroid cancer. And in fact, thyroid cancer is one of the first examples of the use of theranostics dating back to the 1940s when Saul Hertz first used radioactive iodine. And so broadly, just like you pointed out, it means the use of a diagnostic test to predict the likelihood of response to a therapy. It can also be used to assess the response to that therapy also. In the setting of thyroid cancer, really what we want to know is what that post-therapy scan will look like before we actually give the radioactive iodine or I-131. We're all familiar with those cases where someone has metastatic disease, or we give them a big dose of radioactive iodine and we just see nothing but salivary glands on that post-treatment scan. We want to try to avoid that. The use of theranostics and pre-therapy scans is used to varying degrees in thyroid cancer management at different centres around the world. And it's part of a balance between healthcare costs, patient inconvenience, and potential side effects that determines how and when it may be used. But ideally, you do an imaging scan to see if the patient has intense iodine uptake at any sites of disease, and then you may choose to proceed with a high dose of radioactive iodine or I-131, and that amount can be calculated with dosimetry. And then following treatment, you do a post-therapy scan to confirm the iodine has gone where we expect it will, and then that can inform follow-up and better characterization of the disease state and consider retreatment at some stage in the future. But whilst on the one hand, we can give a higher I-131 activity in patients with known iodine uptake at sites of disease, personally, I believe it's most relevant to try to avoid that futile therapy in patients that don't have any iodine uptake at all. And I think, this has real value in thyroid cancer imaging, even more so today when there are other treatments available. Decades ago when there were no other treatments, it was really just, go hard, give whatever you can, there's no other option. But today, I think that's the real value of theranostics, is to be able to do both of those and particularly avoid futile treatment. And so one of the ways that we've done that, my team, we've done a study looking at the management impact of I-124 PET on thyroid cancer management. And, a change in administered activity, choosing to go from maybe, 6 or sort of 160 millicuries up to a higher dose, that's considered a modest change in treatment approach. And it's very difficult to show that with that higher single dose of treatment is better than giving 2 smaller doses, for example, if they're spread apart. And there's many factors to consider to determine the optimal timing, the frequency and dose, and it's really not very straightforward and hard to prove that there is a benefit in that approach. But from our perspective, when we did this study, it's very simple to show that there is very high management impact if you were planning to give a high dose of radioactive iodine, but now you choose not to give any treatment at all because you know it will be futile, and then save the patient from unnecessary side effects and also save significant healthcare costs by avoiding unnecessary hospitalisation for several days. So that's been a key focus also of how we use pre-therapy imaging at our institution. The next aspect of theranostics relates to the choice of the test. We know that modern theranostics approach works very well in some other cancer types, like in prostate cancer with PSMA PET or NETs with dotatate and Lutathera, where we just have a simple PET scan that can be easily repeated whenever required without any additional preparation. Now, unfortunately, it's slightly more complicated in the setting of thyroid cancer, where there's a need for sometimes complex patient preparation with TSH stimulation, low iodine diet, planning, needing to book an inpatient bed for I-131 therapy, and then, potentially choosing which of these types of iodine imaging will be used. However, it is actually very beneficial because in the right circumstance, iodine for the targeting of thyroid cancer can perform exceptionally well. The intensity of uptake we get on an I-124 PET in the appropriate patient is really extraordinary, and we don't see that in any other tumour types. It is so well targeted. Getting SUV maxes of over 1,000 is really quite extraordinary localization in the right patient. And so to do this, you really need a sensitive imaging test if, on the one hand, one of your options is to omit a potential therapy to avoid false negatives. And unfortunately, using I-131 as a diagnostic scan or using I-123 SPECT-CT scans, they're just not very good when you compare it to a post-therapy I-131 scan, okay? So when you look at that post-therapy scan, unfortunately, low-dose I-131 and I-123 are pretty terrible in predicting what you see. I-123, in fact, is only about 40 to 60% sensitive, and it's worst for those small lung metastases. And I-131 is quite poor in that setting of small disease as well. So unfortunately, using either of those tests, you cannot use those to omit therapy. You can only use it to potentially increase the dose. We tend to avoid that in our setting, and we just use I-124 PET, and we use that combined with thyroxine withdrawal in the setting of metastatic disease, and in which case we know it's very accurate. 98% accuracy in correlation between even small lesions you see on an I-124 PET and what you see on the post-therapy scan.
That's terrific. I think the point really is very important. That nowadays radioactive iodine is only going to be given to those whom we think it's going to benefit, and that's just really a paradigm shift. Can you tell us a little bit more about your approach at the Royal Brisbane and Women's Hospital?
We use a different approach and it's stratified according to patient risk and clinical scenario. So, in those patients who are referred to us, post-surgery for their ablation, we pretty much use modified American Thyroid Association criteria like most centers, and including post-operative thyroglobulin levels to assess risk. And then we treat patients empirically in that setting with either a lower dose of sort of 1 gigabecquerel or about 30 millicuries, and in other instances about 4 gigabecquerels or 110 millicuries using thyrogen stimulation in that setting. And that's sort of straightforward adjuvant therapy. We're reasonably conservative in our approach. We're only really treating those at sort of intermediate and higher intermediate risk. And we tend to use the lower doses, particularly in either younger patients or those where, it's slightly more borderline in our institution to treat them. And particularly where it's useful to have a post-therapy scan to complete our assessment and risk stratification. In patients who've had proven, loco-regional recurrent disease, particularly in the neck, when they're referred to us post-surgical resection, we'll typically, again, use I-131 therapy with thyrogen stimulation, typical low-iodine diet, and we tend to use a slightly higher activity in that setting of proven recurrent disease in case there's any small volume residual disease. And we'd use in the order of sort of 4 to 6 gigabecquerels or 110 to sort of 160 millicuries. Whereas in patients with suspected or proven distant metastatic disease, we do treat these differently. So we'll use thyroxine withdrawal, TSH stimulation in that setting, and we typically use that higher end of the activity of about 6 gigabecquerels or 160 millicuries. If patients are likely or proven I-131 avid, so we're giving a follow-up therapy, we know they were iodine avid on their previous post-therapy scan, maybe we know there's still some structural disease on a CT or they've got persistently elevated thyroglobulin, we'll just proceed directly to their subsequent I-131 therapy. We don't do dosimetry in that setting or any pre-therapy imaging because it won't really change what we do. We know we're going to follow up typically about 9 months, or somewhere between 6 to 12 months after that previous therapy. But it's in those patients where there's more of a suspicion that they may actually have non-iodine avid disease. So perhaps they've had an FDG PET that's intensely avid. Maybe the disease is progressive and it's progressing more quickly than we would have anticipated. Or maybe we think there possibly may have been some disease on their initial post-therapy scan, but they had a big thyroid remnant. We're just worried there may have been sink effect, which is absorbing the iodine into the thyroid remnant. And it's in those patients where a bit more uncertainty, we'll typically do those with an I-124 PET. And that's where we think there is some real value in the most management impact in avoiding a futile therapy. Because it is really all about how you most appropriately use your resources in any institution. At our institution, it's not feasible to do an I-124 PET on everyone.
So really, depending on the case, the selective use and selective doses. You mentioned dosimetry, and we hear about it, and some say that you can use it to give a personalized dose. Is it really important?
Yeah. So look, dosimetry is interesting. I've talked before how it has had varying use over the years. We particularly use this in clinical trials In our own clinical practice, we don't tend to adjust the dose too much, but there are a few elements to it. And to give you a definition, essentially dosimetry is the principle of modeling, in this setting of thyroid cancer, how iodine is distributed, metabolized, and excreted by the body to predict the radiation dose that will be delivered either to targeting a tumor to have an effect, but also what the dose will be to normal organs to ensure that that radioactive iodine is given within a safe level. So I am fortunate to work in a large teaching hospital here in Brisbane. We've got one of the biggest nuclear medicine sites in Australia. And so there's an excellent team of medical physicists we've got here who are particularly interested in dosimetry and do a fantastic job, supporting what we do here. So with those two main components to dosimetry, first, we talk about working out the maximum tolerable dose to normal organs. And so in most patients with thyroid cancer, the dose-limiting organ, which is kind of, where is the toxicity most likely to limit the amount of radioactive iodine we can give, for most patients, it's the bone marrow. And so we measure the dose of radiation to the blood to estimate this. And we like to keep that less than 2 grays of radiation dose to the bone marrow. Now, the way we do this, we take some blood samples at 2 time points, and we can then monitor the change in activity in the blood. We measure that in something called like a little Geiger counter or well counter, and that will determine whether we can give a safe activity and what that highest safe activity would be. However, in some cases, such as particularly patients who've got diffuse lung metastases, this is usually in those younger patients with metastatic papillary thyroid cancer, there is a risk of pulmonary fibrosis if you give a very high dose of I-131 in that context. And so in those patients, we also estimate the whole body dose estimated at 48 hours to assess what that risk would be and ensure we don't give them too much radioactive iodine. The second aspect of dosimetry when we're using I-124 PET is called lesional dosimetry. So we already know what the highest ceiling of what possible dose we could give. Now, sometimes this is up to, 500 millicuries or 15 or more, 20 gigabecquerels. Now, it's very rare, and we never go that high in our institution, but it's good to know where the ceiling is to really know what that safety margin is. And then we go on to look at the lesions. And so really, this is on the PET scan. We can measure what the actual amount of activity is attributable to any lesion. And the physicists then they'll measure that and they'll attribute that to within the volume of a particular lesion. It has to be something measurable, ideally over a centimetre, typically a lung metastasis or a large node. And then they'll attribute the radioactivity to that at different time points. And then using some complicated maths and some, fancy computer programs, they'll then fit an uptake and clearance curve over time that passes through those points. They also apply a couple of corrective factors depending on lesion size, etc. And then it's the area under that activity time curve that tells us the dose. And so it's those 2 bits of information. We know the upper ceiling of what we could possibly give, and then we just want to decide, at least with a reasonable dose, or with a reasonable dose of I-131, are we going to deliver a meaningful dose to those tumours? So can we give more than 20 gray is sort of the goal. Ideally, we want it to be much higher than that. Ideally, we want to be giving in the hundreds of grays. But that's sort of a base level, and certainly in clinical trials that we do, it's a commonly referred to threshold of being 20 gray to have a meaningful effect. There are a few important things to consider about dosimetry, though. Firstly, it's the generalizability and reproducibility. So it depends really on what your center is measuring, what assumptions are used, because, what one center measures, as you understand, there's a lot of different factors that go into that. There's a potential that another nuclear medicine department somewhere else in the world might use either slightly different calculations, slightly different assumptions. The cameras may be of a different generation. They may not be as accurate. And so that's a really, really important issue, because ideally this is standardized across the world. So if you predict 50 gray at one site, that's equivalent to 50 gray at another. In Australia, we have got quite a well-developed network of nuclear medicine sites. It's called ARTNet, the Australian Radiopharmaceuticals Trial Network. And so it's been a key initiative over the last decade that supported a variety of high-profile multi-center Theranostics trials. And to do this, we'll get a small dose of calibrated amount of radiation of iodine in this situation. We actually ship that in a standard, what's called a phantom, which is like a standard bit of plastic, and we fill that up with that little bit of iodine, and we actually ship that to the different sites involved in the trial. There's sort of up to 10 sites in Australia. And then we measure it, calibrate it, and make sure that every site is measuring the same thing. And there have been some really interesting findings that in actual fact, in some instances, it wasn't. And so that's sort of a really important principle to realize that just if one centre says you do this and you're giving 50 gray, it may be different. And so without that kind of calibration, it really is important to have clinical data to support your approach. You need to know that your centre is safe giving that amount of activity. You just can't rely specifically on something quoted in a study. Okay, it's a reasonable estimate, but it's important to have that experience and not just to go out blindly and say that. You need to be able to compare that to other centres. Unfortunately, in nuclear medicine at big academic centres, this happens all the time. We collaborate with other sites, and there is that correlation for this complex area of dosimetry. The other thing is there's some assumptions. So it is an estimate based on several assumptions about how your body's handling iodine. Typically, it's done, the more measurements you do, the better. And ideally, you're doing 4 measurements, but that's quite complex. So often we'll just do 2, and we're fitting quite a complex physiological curve to that, so there may be some error. We allow a reasonable safety margin, but again, has to be grounded in clinical experience. And so we typically, although it may say we can give up to a high activity of iodine, we tend to go well within those safety margins. And overall, it's driven by clinical experience.
Thank you for tuning in to this riveting discussion on unraveling the mystery and clarifying when, why, and how one should use radioactive iodine treatment. Due to the depths and importance of our conversation today, we've decided to extend our chat into a second part to ensure that we cover everything thoroughly. So don't go anywhere. We'll continue our discussion in part 2 of this episode, where we will delve deeper into this subject with our esteemed guest, Dr. David Pattison. So stay tuned for part 2 and join us as we unravel more mysteries of radioactive iodine. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. Thyro Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit thyro.expert/subscribe or click in the link in the description. Thank you for tuning in to this episode of Thyro's Voices of Wisdom podcast. Join us next time, and in the meantime, take care, everybody.